Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very important exam oriented topic, neurological history. What is the lesion? The etiological diagnosis. We are going to talk about neurological history taking. What is the lesion? The etiological diagnosis. Whenever we approach a person suffering from neurological disorder, we basically ask two questions to clinch the diagnosis. The first one is, where is the lesion? The anatomical diagnosis. Second is, what is the diagnosis? What is the lesion? Etiological diagnosis. So where is the lesion? The first question. Second is, what is the lesion? Where is the lesion? I made a separate video last time. So I'll not be discussing where is the lesion. Today we'll be discussing what is the lesion, the etiological diagnosis. So when we approach a person suffering from neurological disorders, the two questions are, where is the lesion? That is for anatomical diagnosis. Second is, what is the lesion? The etiological diagnosis. As I said in my last class, when we approach a neurological disorder, or for that matter any disorder, we should have Bayes' theorem in our mind. The rare manifestations of common disease are commoner than the common manifestations of the rare disease. That is, common diseases are common. Always remember that common diseases are common. Right. So now let's see the neurological history. What is the lesion? The etiological diagnosis. So to understand that, we need certain basics followed by a few important historical points. First is, we know that the brain has the gray matter and the white matter. The gray matter produces certain clinical manifestations. The white matter lesions produces certain clinical manifestations. When the gray matter gets affected, they have cognitive impairment. So they have cognitive impairment. And when the gray matter gets affected, they'll have seizures. So if a person has got seizures or cognitive impairment, you have to think of gray matter disease. And then we have basal ganglia also. So if that gets affected, you will have movement disorders. So a person who has cognitive disturbances, movement disorders and seizures, it's a gray matter disease. But if a person has got tract involvement, that is the white matter is involved. So when the white matter gets affected, when there's a lesion in the white matter, you have motor tracts being affected. So motor symptomatology, you have sensory symptoms, you have visual symptoms, you have cerebellar symptoms. So if you have cerebellar, visual, motor, sensory clinical findings, that is a white matter involvement. Whereas if you have cognitive impairment, movement disorders and seizures, it is a gray matter disorders. Especially when we talk about inborn errors of metabolism, we have certain disorders which affect only white matter, we have certain disorders which affect only gray matter. Right. Here we go into the history now. So the most important question we need to ask in history is the temporal course of the illness, or the temporal profile of the illness. How did the disease start? Whether it is acute, subacute or chronic, and how it went on, how it progressed. The most important question we need to ask is the temporal profile of the illness, temporal course of the illness, whether it is acute, subacute or chronic, because it gives a lot of information. Suppose if it is acute in onset, that is seconds and minutes, we need to think of a vascular disorder. So most common will be a vascular disorder. Person is absolutely alright, suddenly he develops a weakness on one side. Always think vascular. Stroke, that is the most common cause. Then person may have seizures. After seizures, he may develop post-ictal weakness, Todd's paralysis. That also can present as a sudden onset or acute onset of symptoms or weakness. Then migraine, complicated migraine. They can also present with sudden onset of weakness. So when a person has got sudden onset of weakness, we think vascular, that is cerebrovascular accident or stroke, or anything to do with vascular, like vasculitis secondary to TB meningitis or syphilitic meningitis. Then we can think of seizures, that is Stotts paralysis, post-ictal weakness, complicated migraine. Sometimes persons present with feign illness, pseudo weakness. So demyelinative disease can present an acute to subacute onset. So acute onset, we generally think of vascular, seizures and migraine. Suppose if it is subacute in onset, that means it takes few hours to days to develop. Then we think of other causes like toxic, metabolic like hypoglycemia, infections like meningitis, bacterial meningitis, or any inflammatory disorder. So if it is subacute onset, developing over hours to days, we think of toxic involvement, metabolic involvement, infective pathology or inflammatory pathology. Suppose it still takes a lot of time to develop, a chronic process, slowly progressive, months or years, we think of a degenerative disease like a motor neuron disease or Parkinson's disease going on for months and years together, neoplasms or chronic infections or gradual intoxication. So slowly progressive going on for months to years, we think of degenerative disorders, neoplasms or chronic infections or gradual onset of intoxications. Right. Suppose a person has got fever and then he's got neck stiffness and altered sensorium. Fever, neck stiffness, altered sensorium, headache. Think of infective pathology. In this case, headache, neck stiffness, you have to think of meningitis. So fever, headache, neck stiffness, altered sensorium, we think of meningitis. Suppose the course is not progressive. It relapses and remits. It worsens and then becomes alright. Worsens and then becomes alright. So if you have such a type of a temporal profile, you have to think of multiple sclerosis, where it is disseminated in time, disseminated in space. Multiple systems can get affected. So relapsing remitting type, disseminated in time and space, think of multiple sclerosis. Then after the temporal onset of the illness, which is very, very important, we ask family history because some diseases run in families. Genetic disorders like Charcot-Marie-Tooth disease or Huntington's disease. Then when we try to elicit history, we should always ask about the associated medical disorders. Persons may be having hypertension, diabetes and hyperlipidemia or dyslipidemia. So these are the risk factors for stroke. So if a person has got hypertension, diabetes or dyslipidemia, there's a chance that the person having a stroke is very, very high because these are the risk factors. Then a person may have space occupying lesion. Then we have to go with the associated condition. If the space occupying lesion is there in a valvular heart disease and he has fever, we have to think of abscess. And a space occupying lesion in a person taking anticoagulants or coagulopathies, you have to think of hemorrhage. A space occupying lesion, a person who's having immunodeficiency, acquired immunodeficiency, you have to think of disorders like lymphoma or toxoplasmosis. In endemic countries, especially India, we have to think of tuberculoma or neurocysticercosis. Suppose a person is having cancer, we have to think of a metastatic lesions. So if a person has got space occupying lesion, the etiology will depend upon the underlying conditions and the associated conditions. Right. Then if a person has got collagen disorders, he may have dissection of cranial arteries and subarachnoid hemorrhage. So we have to ask history of collagen disorders. A person, if he has got any dysthyroid states, hypothyroidism can produce peripheral neuropathy. Then we need to always ask history of drugs. Aminoglycosides can cause a neuromuscular junction disorder. Vincristine can cause peripheral neuropathy. Statins can cause myopathy. Antiplatelets like aspirin can cause hemorrhage. So we need to ask about history of drugs, aminoglycosides, vincristine, aspirin, statins, all these things also can cause a disorder of the nervous system. Then toxins, the most important toxin we need to ask is alcohol. Alcohol can cause peripheral neuropathy, alcohol can cause vitamin B1 deficiency, Wernicke-Korsakoff psychosis, alcohol can cause cerebellar degeneration. So it can cause peripheral neuropathy, cerebellar degeneration, and it's a risk factor for stroke along with smoking. So we need to ask about alcohol history. Right. And then a person's diet is also very important. Suppose a person is not taking a good adequate diet, a deficiency of vitamin B12 can cause subacute combined degeneration, vitamin B1 can cause Wernicke-Korsakoff psychosis, or copper deficiency can cause myelopathy. So all these are all important questions we need to ask when we encounter a person who is likely to have a neurological disorder. Right. So these are the important pertinent questions. So now there's a differential diagnosis of neurological disorders. So how do we remember? It is easy to remember if you remember an acronym, vitamin D, VITAMIN, vitamin D. If we remember this, we can remember all the neurological disorders. V stands for vascular. I stands for infective, inflammatory or immune conditions. T stands for trauma. A stands for alcohol and toxins. M stands for metabolic disorders. I stands for inborn or congenital or genetic disorders. N stands for nutritional or neoplasia. So vitamin D stands for demyelinative disorders or degenerative disorders, which can give rise to dementia, D. So if you remember vitamin D, we can remember all the neurological disorders, the differential diagnosis of neurological disorders. Now let's see the important points of these disorders. First, we'll focus our attention on vascular disorders. The commonest is vascular disorders in neurology. The inpatient wards are generally filled up with stroke patients. Vascular, that is the most common cause of neurological admission. Vascular. The risk factors are age. As you become aged, the risk of atherosclerosis increases and your tendency to get stroke also increases. So age is one of the important irreversible or non-modifiable risk factor. Hypertension, diabetes, dyslipidemia, previous history of transient ischemic attack, smoking, carotid artery stenosis or cardiac disorders like atrial fibrillation, all these are risk factors for stroke. So when we approach a person suffering from stroke, we need to know all these risk factors: age, alcohol, lipids, hypertension, diabetes mellitus, TIA, smoking, carotid artery disease and cardiac disorders. Stroke, we have to have an overview. Stroke is broadly divided into ischemic stroke and hemorrhagic stroke. Ischemic strokes are the commonest. About 80% is because of ischemia and 20% is because of hemorrhage. Ischemia is a cessation or decrease in the blood flow. Hemorrhage is the rupture of the vessel causing bleeding. So 80% is because of ischemia. And ischemia, basically there are three conditions: thrombosis, where there's a blood clot, or embolism, where a blood clot goes from one area to the other area, or hypoperfusion. Example, when there is decreased cardiac contractility, the ejection fraction goes down, the blood flows but very slowly. And the proximal parts of the vessels can get good blood, but as you go to the distal parts, the blood may not flow at all. So thrombosis. Thrombosis, again, you have two types. One, the large arteries causing atherosclerosis, or the small artery stroke, which you call as lacunar strokes. Embolism could be because from the cardiac source or from the carotid stroke. Hypoperfusion will cause watershed infarction. When there is hypoperfusion, the proximal arteries get good blood supply. But as you go to the distal parts, the blood supply slows down, and the distalmost part, the blood completely stops. And therefore, when there is a hypoperfusion, it is the distal parts of the arteries get affected. So when there is hypoperfusion, there may be a decreased perfusion between the ACA and the MCA, what you call as anterior watershed infarction, or between MCA and PCA, what you call as posterior watershed infarction. So posterior watershed infarction, usually the parieto-occipital cortex gets affected. You develop balance syndrome, asimultaneous. In anterior watershed infarction, the shoulders get more affected. You get man-in-barrel syndrome. Hemorrhage. Hemorrhage, again, it is 20%. Basically, you have an intracerebral hemorrhage, which is 15%, and subarachnoid hemorrhage, which is 5%. Hemorrhage usually produces raised intracranial pressure, increased intracranial pressure. When there is increased intracranial pressure, the meninges get affected and therefore person presents with headache. Subarachnoid hemorrhage, which is 15%, is either due to trauma or because of aneurysm rupture. Subarachnoid hemorrhage also produces headache. So intracerebral hemorrhage produces headache because of raised intracranial pressure. Subarachnoid hemorrhage produces headache because of meningeal irritation. Right. These are the important points we need to know in the stroke. Vascular. Then comes infections. Infections, meningitis. Meningitis, and the meninges get affected, person develops headache. There are no pain receptors in the brain. So even if you cut brain, there is no pain. But meninges is highly pain sensitive organ. So whenever there is inflammation or infection of the meninges, they'll have severe pain. That's why we see pain in meningitis where the meninges get affected, and in subarachnoid hemorrhage where the blood seeps in under the arachnoid space and affects the meninges and person develops headache. So meningitis infection, we have to think of meningitis. Usually the positive organisms are Streptococcus pneumoniae and the Neisseria meningitis. If just not meninges, if the brain gets involved, they'll have symptomatology suggestive of brain involvement like altered sensorium, seizures, or focal neurological deficit. In that case, we have to suspect viral encephalitis. If the brain gets affected, you call that as encephalitis. We suspect viral encephalitis. Usually HSV encephalitis, if we give acyclovir, definitely the prognosis will be better. This is about infections. Trauma, head injury. When there is trauma, there are two types of problems. One, the middle meningeal artery can get ruptured where there is a torrential bleed and will cause extradural hematoma. Extradural hematoma is dangerous. We have to immediately call neurosurgeon, take the hematoma out, persons will become alright. They can develop lucid interval also. Second is subarachnoid hemorrhage, where there is a venous rupture, so blood slowly starts trickling down. This is not as dangerous as extradural hematoma. Old persons may have a trivial injury, might have had a trivial injury, blood may be slowly starts trickling it then diffuses from the frontal cortex to the occipital cortex because it is under the dura, so it can nicely slip, and after some time person may present with dementia. So one of the treatable causes of dementia is subdural hematoma. If you take the hematoma out, person's dementia also improves. So this is about trauma. Alcohol. As I said, alcohol is a toxin, can cause various neurological disorders. It can cause seizures, it can cause peripheral neuropathy, it can cause B1 deficiency, Wernicke-Korsakoff psychosis, it can cause alcoholic cerebellar degeneration. Then metabolic. Metabolic, we have vitamin B12 deficiency causing subacute combined degeneration. We have vitamin B1 deficiency causing Wernicke-Korsakoff psychosis, copper deficiency causing myelopathy. You can have hypoglycemia, which causes metabolic encephalopathy. Hyperglycemia non-ketotic hyperglycemia can cause chorea. Hypothyroidism can cause peripheral neuropathy. We have Wilson's disease, we can cause dysarthria, gait, ataxia, dystonia, tremor, Parkinson's, all extrapyramidal features. So this is about metabolic. Then inborn, congenital or genetic. We, in neurology case presentation, history taking, we always ask about neurocutaneous markers. We stress on neurocutaneous markers. Why? Skin is usually will have some deficits if the nervous system is affected, because the nervous system and skin both develop from ectoderm. And therefore when there are skin disorders, especially genetic, brain disorders, especially genetic, you can see it on the skin. So neurocutaneous disorders are common. That's why we ask for neurocutaneous markers, because brain and the skin develop from the same ectoderm. So one of the common disorders of neurocutaneous disorders is neurofibromatosis. Then we have nutritional deficiency. As I said, B12 deficiency can cause subacute combined degeneration. Then we have neoplasms. Neoplasms could be intraaxial, where it goes and invades the substance, so it is malignant, prognosis is poor. Extraaxial is only compresses the brain, and therefore it is benign, it can be removed, or sometimes it can spread as metastasis, or sometimes without spreading it can cause manifestations known as non-metastatic manifestations. So neoplasm can present in many ways, varied ways. And then finally we have the demyelinative disorders like multiple sclerosis. As I said, you have the relapsing and remitting type, disseminated in space and time. Then you have neuromyelitis optica. It is multifocal. It affects the optic nerve as well as the spinal cord. Then you can have transverse myelitis where the entire spinal cord is cut off. You can have leukodystrophies, as I was telling the initial part of my lecture, when the white matter can get affected, motor, sensory, visual and cerebellar pathways, you call that as a leukodystrophies. Then the degenerative diseases like amyotrophic lateral sclerosis, they take long time. They have upper motor neuron signs and lower motor neuron signs. Some of the degenerative disorders can present as dementia, like Alzheimer's dementia, Lewy body dementia, and Parkinson's disease also can present with dementia, and frontotemporal dementia also can present as dementia. So this is an overall view of neurological history. What is the lesion? Etiological diagnosis. As I said, when you approach a person for a neurological disorder, when you start taking history, the two important questions which should be on your forefront is, where is the lesion, the anatomical diagnosis, followed by what is the lesion, etiological diagnosis. Where is the lesion, anatomical diagnosis? I made a separate video, the previous video, neurology history taking part 1. What is the lesion, the etiological diagnosis? This is neurological history part 2. So in this video I discussed all about etiological diagnosis, what is the lesion. So if you go in this methodical order, where is the lesion followed by what is the lesion, and ask pertinent questions, you can definitely clinch the diagnosis. I've enjoyed giving the lecture, and I hope you have also enjoyed listening to this lecture. If you have any doubts, suggestions, kindly post it on my YouTube channel. If you have liked it, kindly like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.